Okay, great. Okay, so this is the public hearing of the Human Services Subcommittee of the Advisory Committee on Warrant Article 21, the Medicare for All resolution. And I'm Susan Granoff, Chair of the Human Services Subcommittee. And I'd like to introduce the other subcommittee members who are present. And as I say their name, please wave. And okay, I'm going to start with Alec Lebovitz, David Mark Goldstein, Fran Perler, and Perry Grossman. Okay. And we have one additional member who may be arriving a bit late, but I will identify that person when they come in. So, Francis, to start with, do you have any kind of presentation or opening words that you would like to say about your warrant article?
Well, really, the opening, I wish that everyone had the petitioner's explanation that I sent to the committee, because really my opening words are that, as all of you have probably even experienced personally and know, in any case, healthcare in this country is in a crisis. People make decisions like skipping meals, like not retiring, like staying in jobs they hate and that are stifling them. Young people take jobs that they don't like because they have to have health insurance. Huge profits are being made, not by physicians, but by large companies, which are interested not so much in healthcare, but in those profits. And the reason that I petitioned for this, and that many others have are wanting this, is that the single payer system would, first of all, save Brookline a huge, huge amount of money that the town has to pay to contribute to employees' healthcare costs, and that we would all be paying much less in premiums, getting much better services, more equitable services. There are all over the developed world, except for in the United States, different versions of single-payer health care are in existence. And you know, what I mentioned in the petitioner's explanation is that Massachusetts was in the forefront in, I think, 2006 in trying to push for more equitable healthcare, and we should remain in the forefront and push Massachusetts toward this system. It would be an amazing achievement. So is it possible for me to introduce anyone, or you tell me what?
Right. What the way we normally run a public hearing is we give the petitioner a few minutes to do introductory comments like what you just did, and then we open up the public hearing part, and we allow anyone present to make a statement of about 2 minutes. We would like, you have to sign up in the, I guess the chat room would be the best way of doing it. And David Mark will be letting me know who's next on the list. You have, when you begin your statement, we would appreciate for the record that you give your name and any organization or official position that you hold in the town as part of the identification of who you are for the record. And then you have 2 minutes to make a statement. And then we'll go on to someone else. And then when we've completed all of the comments, I'm going to hold the public hearing open technically, but then we would move on to the members of the subcommittee having an opportunity to ask questions of the petitioner and to make comments. And then we will move on to having a discussion among ourselves and vote on any recommendations concerning this warrant article that we will then make to the full advisory committee and to town meeting. And so that's essentially the procedure. So right now, the public hearing portion of this meeting is open, and anyone who would like to make a comment should simply sign up and go right ahead. If there's anyone that you'd like to introduce in addition after people have made comments, then of course, Francis, you can certainly introduce anyone that you would like. David Mark.
So, Francis, have you said what you want to say at this point, or would you like to go on?
I am happy to yield the floor to people who have worked in this area much longer than I have and who are experts in this field. I'm putting Pat Berger in the chat, but I don't know whether, oh, he's there. Okay, good.
Okay, and you'll have an opportunity to discuss this with us. You'll be, responding to our questions, and you'll have an opportunity to say additional things throughout the meeting. But this is an opportunity for people who aren't the petitioners to make a statement.
Right. So first up is David Cohen.
Okay. Hi, David.
Hi. My name is David Cohen. I'm co-chair of MassCare, the coalition that has put together the legislation for single-payer health care. And I just wanted to quickly say, I think it'd be better if you ask questions, but what we're really seeing around Massachusetts right now is a lot of towns and cities being put into real financial crisis because of the escalating healthcare costs. And also, with the escalating healthcare costs, it means employees are paying bigger share, more out of their paychecks. So we really see our legislation for single-payer healthcare as a way to improve health coverage for everyone in the state and also save a lot of money for cities, towns, and employees and businesses all over the state. So I'll be glad to answer any questions when we come to that. Thank you for holding this hearing.
Okay, thank you. Who's next, David Mark?
Ms. Berger.
You.
Me?
You're next. You're up.
Oh, hi. Sorry,
Somebody else signed you up, so
I did. I did.
no, I just didn't hear my name. I'm sorry.
Also, people speak up because some of us may have just need people to speak up.
I totally understand.
So my name is Patricia Downsberger. I'm a doctor and I'm a primary care physician. And I have worked at Neighborhood Health Center, the Harvard Community Health Plan, which was at the time I joined, had just become a managed care plan, which I did not like, and I only stayed 2 years. And then I spent the last part of my being a doctor in a private office here in Brookline in primary care. And I'm asking the planning board to support Medicare for All as the way forward to provide the citizens of Brookline and Massachusetts with affordable, caring, equitable, and accessible health care that would cover everyone. So I prepared kind of a little bit longer talk, so if I get too much, just tell me to.
Okay, well, one possibility, we do want to keep it to a maximum of, say, 3 minutes, but you can also submit whatever you intended to say in writing, and then we'll just include that as part of what we present to the full AC. That would count as a statement as well. We have to stop everything by 7 o'clock because we have the full advisory committee is meeting at that time. So
Sure.
that's why I'm being somewhat strict about the amount
No,
of
I
time.
understand. I
But
understand.
but definitely
Maybe a
take
little
the
more.
full 3 minutes.
Yeah.
So healthcare is a human right. In America, everyone should be able to access high quality, equitable, and affordable healthcare. But our healthcare system is now so dysfunctional that people don't even realize that it could be different. It doesn't need to be so complicated with multiple payer plans and other confusing and often misleading quotes. Rational decisions about healthcare options are anxiety-provoking and often impossible. Corporate greed, the tantalizing incentive for fortunes and power, is destroying the American healthcare system. The health insurance industry has used healthcare as an extremely lucrative cash cow. It is multiple ways of increasing profits by denying payments for legitimate claims, delaying payments to physicians, inflating diagnoses to get higher reimbursements, cherry-picking healthy patients, and canceling the sickest, costly patients. It is ironic that health insurance companies do not need to exist in a well-functioning healthcare system. Regular Medicare, for example, does not use insurance physicians and the Medicare payer. It saves huge amounts of money and avoids tremendous waste and profiteering. The pharmaceutical industry is run by huge profitable drug companies that have been given approval to charge high prices for some medications that in many cases are life-saving, like insulin, but are so expensive many people are unable to afford them.
Okay, you have another 30 seconds.
Okay, and big hospitals, because of their size and prestige, spend money on high salaries in the millions for flashy buildings and perks for high-level employees that smaller hospitals can't afford. This is a huge waste of money.
Can I just add one thing that actually Pat left out, which is she wrote this. Our system is the most expensive system in the world, but it is the corporate moguls in the insurance industry, the big hospital systems, and the pharmaceutical industry who bend the rules and take the money. So anyway,
Thank you.
I thought that was helpful.
Okay.
Sure.
Who's next, David Mark? Thank you very much for Pat, for your statement. David Mark, who's
Next up
next?
is Jackson. Help me with, is it Diane or Deanne?
Diani.
Yeah.
I'll try to go quick because I know we're on a time crunch. And just talk about why I think that this piece of legislation represents such an opportunity. 6 years ago, it seemed like we were on the verge of an unprecedented moment in our country where Medicare for All had been adopted as part of the Democratic Party's platform, and it had overwhelming popular support. And it seemed, at least to me, like the US was going to finally remedy this basic, obvious injustice in our system and guarantee healthcare coverage to all citizens as a human right, the way that every other developed country has it. Well, that didn't come to pass. And today it seems less likely than ever that we'll get something like that passed at the federal level, which is why a lot of people have, myself included, have put their hope in state level initiatives, which can hopefully act as kind of testing grounds so that we can see such a bill in action. And the hope is that eventually it'll grow in popularity enough that it can be implemented on a national scale. This is what happened in Canada in the 1940s. Saskatchewan became the birthplace of Canada's system, and 17 years after it passed, all of Canada was covered under health insurance. Now, that strategy has its own challenges. State governments can't deficit spend, so state level single payer initiatives have to be fully funded. And in states with low GDPs like Vermont, that represents a major hurdle. And that's why, in my view, the states where Medicare for All is most likely to pass are New York, California, and Massachusetts, which have robust Medicare for All movements and large state budgets. Massachusetts, in particular, has long been a leader in healthcare innovation, which makes it, in my opinion, a good choice. And initiatives like this come along a few times every generation. I think this bill represents a rare opportunity to change not just the lives of the people in Massachusetts, but potentially the direction of the country over the next 10 to 20 years in this crucial area. It could resolve one of the basic inequities in American life, something that separates us from the rest of the developed world and which has become increasingly unsustainable every year as it continues to go on. And so I think this is our chance for Massachusetts to become an example for the rest of the country at a very dangerous, unprecedented historical moment while saving a lot of lives and money in the process.
Thank you, Jackson. Who's next?
Nobody
Anyone?
else, nobody else has signed up at this point, Susan, if you want to.
Okay, I'm going to hold the public hearing open in case someone wants to add a comment. But I'm going to throw it open to questions from the subcommittee members. And I'd like to start off with one question. I did some research and correct me if I'm wrong. Currently, there hasn't been a single state that has fully implemented a Medicare for All program. I know that Vermont tried to do that in 2011. And in 2014, they essentially said that they couldn't manage that. And I'm wondering, why did that fail, considering that you had the support of the governor and, of course, Bernie Sanders? Who would like to?
I think Jackson has his hand
Yeah,
up.
because you had alluded to that. So
Yeah.
please fill us in on that.
I will try to be brief. I wrote a study about the Vermont bill for the MassCare website, actually, because this is a question that we get a lot. So Peter Shumlin, who is the governor of Vermont, ran on this policy of a single payer healthcare system. And it was basically there were two phases. There was the implementation phase and the funding phase. And in the initial implementation phase, it passed. It was I think, a binding ballot initiative in Vermont. There were three economic studies that were done of the Vermont bill. There was the UMass Amherst study, there was the Harvard study, and then there was the one that was commissioned by the state of Vermont itself. Now, it's very important to recognize each of the three studies showed that the bill would save the state of Vermont money. They showed less savings, each one successively. Part of the reason for that was because there were waivers from the federal government, the 1332 waivers as part of the ACA, which were expected to come through and didn't. But even the study that evaluated the most expensive version of the bill said that it would yield significant savings for the state. And I actually interviewed Professor William Shao of Harvard, who wrote the Harvard study of the bill. He confirmed all of this for me, and he said he is kind of a world leader in healthcare. He helped.
Yeah, I read it.
Yeah, he helped Taiwan implement their single-payer healthcare system in the 1990s. And he said that he thinks that the reason why the bill did not pass was because basically, as soon as the first phase, the implementation phase, was passed, and there was a couple of years that were leading up to the funding phase, there was a massive influx of basically industry pressure. There were a huge number of television ads, op-eds, and other basically negative press that greatly swayed the public on the issue. And then Governor Peter Shumlin reversed his position on the issue. And when I spoke to Professor Shao, he said that he thought that Massachusetts would be a better state to actually try it because we are such a healthcare leader.
Weren't there also problems with carve-outs for companies that had multi-state employees, and therefore they were not they didn't have to contribute towards the payroll tax. And I believe the payroll tax was 11 or 11.5%. Is that correct?
I believe 11% is what it was. David Cohen, you're nodding. Do you have something to add?
Well, no, the carve-outs had a big, reason to do with the failure. So once the bill was in the legislature, when they were refining it under some big corporation lobbying, General Electric and IBM, who had big facilities in Vermont, they exempted them, said that they could opt out of the plan. And in a small state of 800,000 people, when you remove a big block of healthy workers, right, younger, for the most part, younger workers who are very healthy, it had a dramatic effect when they then did the next financial study. All of a sudden it changed dramatically. And that was because you were pulling out a lot of healthy people out of the system. And in a small state, that had a devastating effect on the composition.
Thank you. That's very helpful. And I have a second question. I had an opportunity yesterday to speak with State Representative Tommy Vitolo. And as you know, he sits on the joint committee that is that the current bill before the State House has been referred to. And I wanted to get his any concerns that he might have. And he does have serious reservations about one factor. And I think it sort of builds on what you were saying, David. He's concerned that if you have a single state pass a Medicare for all bill and actually create everything that needs to be done and starts it, that people living all over the United States would simply move here.
Oh,
Particularly people who have seriously ill members of their family or have serious illnesses. And therefore, we would then have a disproportionate number of people making use of this service simply because we would be the first and only state providing this. How would you address this, or is this something that just needs to be you assume that eventually there'll be more states and that we wouldn't be the only one?
I would answer that in the first place, when Romney Care was first passed, we heard the exact same arguments that the state was going to be flooded with people moving in to get, insurance coverage. And you can go back and look at letters to the editor and what some of the big businesses were saying, that all the indigenous people would be moving in, and there was no statistic that showed that ever happened. So I think it's the same way when the millionaires tax was passed. Remember, we heard that all the millionaires were going to move out of the state of Massachusetts, and they just released a study saying that hasn't happened at all. So I think we have to disregard, the scare tactics. There will be people moving into Massachusetts, and we need people. There's a shortage of workers to cover all the jobs that are needed in Massachusetts right now. So people who move here and be working will be paying into the system. They won't be just getting it for free.
And can I just add on to David's point, just so everyone's aware? I think what he's referring to with Romney Care in particular was that became the national model for the Affordable Care Act.
Yeah.
But a core plank of that, even when it was rolled out only at the state level in Massachusetts, is guaranteed issuance of insurance, meaning we couldn't deny people coverage anymore for pre-existing conditions. So, I mean, I think that logic is very analogous, because if you were someone who had a chronic health condition and couldn't get coverage in Texas in 2006, I mean, that incentive existed to move to Massachusetts. But to David's point, 20 years later, I don't think we've seen any compelling evidence that there was this big migration into Massachusetts for health coverage.
Right.
I think those decisions people make about where to live and where to move are just too complex to really boil down to a single issue like that.
Can I just chime in with two cents, my 2 cents? First of all, I'm kind of shocked that Tommy is saying this. One of the reasons I voted for him was that I thought he supported this thing. But anyway,
Well, I think he supports the concept. I
right.
think he's just concerned about
But
the
yes,
impact on
I know.
Massachusetts.
But two things. First of all, one could equally, and I think more accurately, say that other states, when they see that Massachusetts has done this, will take the idea more seriously and will follow suit. I think people don't want to leave their homes to uproot themselves. There are so many reasons not to move to Massachusetts from one's home that and David and Alec have both said that this in fact has not happened before, and it wouldn't. I don't believe it would happen.
Mhm. And the second question is, how essential is it to have the federal government pass enabling legislation like the Markey uh, Kana bill that would provide access to federal funding as well as eliminate the requirements to fulfill certain federal regulations
So,
by providing waivers to the plan. It, I know the bill exists. It probably is not going to pass until you have a veto-proof Democratic majority.
well, in our legislation, we look at that problem. So, the most efficient system would be to get the waivers, and all that Medicare and Medicaid money goes into the trust. Then we'd have a true single, just one payer. So all the savings that you get from eliminating doctors' offices trying to have to figure out billing for 100 different insurance companies would disappear. But what we do provide for is if those waivers are held up, we would essentially become a two-payer state. Medicare, people would still be on Medicare, would still get Medicare coverage, but our financial analysis of the money that would bring in shows that if people had to stay on Medicare, we could then reimburse them for the things that Medicare doesn't cover. So so doctors would have to bill either Medicare, Medicaid, or the trust fund, right?
Mhm.
So it makes it a fraction of a bit less efficient. Um, but we would of course prefer to have the waivers, but we think it could be
Mhm.
done without the waivers. And our economic analysis shows that it still works. The savings would be less. The
Mhm.
amount of money that would save would be
Right.
slightly
What
less.
about Medicaid recipients? If again, if there's no waiver, if there's no,
They
if
would,
they
so they
can,
would con
they
they
would
would continue
continue
to be
getting,
covered by
right.
Medicaid, and anything that our trust gave to people in Massachusetts that Medicare didn't cover,
Mhm.
then they would fall under the trust for that
Mhm.
extra coverage.
Okay, I'm going to throw it open now. I've taken more than my share of time. Who else would like to ask some questions?
Okay, Donnell is first. Hold on.
Hi,
Thank you.
Donnell. And this is
Hold on, Susan.
the additional member of
Yeah.
our subcommittee.
Susan, hold on. Alec had a two finger.
And I'll be very
Oh.
brief. I don't want to cut Donnell off, but
ahead.
I just wanted to add to David's point there that the system he's describing with multiple payers and a kind of moving forward with this model without waivers, in a sense, already exists in Massachusetts, and it's called the health safety net. We have another tiered system where if you are someone who is ineligible for Medicaid and doesn't have private insurance, we have an existing state trust that will pay for those people's care. So, in a sense, this is kind of just reinvigorating the current catch-all system Massachusetts has built if the federal government isn't willing to play ball on the waivers. So I just wanted to add that point.
Okay.
Okay,
Donnell, sorry about the interruption. Go ahead,
Donnell.
No problem. Thank you. And thank you, Francis, for putting this forward. Appreciate you doing that. So, I did a little Googling and about Mass Care, the organization, how long it's been around, all that good stuff. I was curious, I've seen a couple of things. How many organizations are part of this group? It's been around since 95, so I was curious about that. So that's one question. I have issues with language endorsing. I would rather support We had a, Susan knows
Right.
what I'm talking
There
about.
has been an amendment to the
Okay.
original motion, and we can talk about that.
Okay, all right,
If
thank
you
you.
want, I can put it up, and I can share the screen and put the language up.
Yeah,
if anybody wants to see it.
Yes, please, I'm
Particularly
sorry.
the last couple of paragraphs, the
thank-
resolved.
Thank you, because I had an issue with that last part. So that's where I was, that's where I was headed. Therefore resolved, the Brookline Irish is coming out, okay, city healthcare.
Okay, can everybody see that now?
Yes.
Yes.
Okay, so yes, this is more in the ball field of what I was thinking, language wise. So I mean, I'm curious on has any other state reps or anybody, I mean, since June of 2025, has anybody like said any positive things about this? Like, you know what I mean? Where's the support coming from other than
Could we not share the screen
that?
there? We can see people's I can't see people's faces.
Okay.
So
I'm okay with the language there, David Mark. Thank you.
okay. We
So
can put it back
that's
up
it. I'm just
if
curious
anyone
on
needs to see it again. And when we actually vote on it, we
Okay.
would, you know, have that up.
So just those two questions.
There's a whole list of I know that on the bill itself that we sent I sent around, there is a list of the legislatures who are supporting it. But I don't know I don't know specifically how that will work out in terms of whether this is likely to pass this year or not. There
But this
had
support
been
the
other
support would help. The support will help, basically.
Yes.
You know, that's what we're getting at with this.
Yeah.
Right.
Right.
Okay. Thank
And
you.
if I could just answer one. So there are 110 different groups that belong to the Mass Care Coalition right now.
Thank you.
And recently we've been getting more and more support from municipalities. So my hometown of Greenfield, at the end of last year, passed. They did a letter of support. They
Thank
didn't
you.
like resolutions. I just spoke 2 weeks ago at the town of Conway. Conway is 5,000 people.
Yeah, they just lost their fire chief. He's actually my son's grandfather's uncle. So it was
wow.
So,
So-
David Weathers. David Weathers.
Okay.
Okay.
Yes.
I'm
So
concerned that we
Conway
may
just
be
passed a
running out of
resolution.
time.
Okay. No, I understand. I just wanted to get in touch on what communities have
Right.
been reached. You know what I'm saying? So thank you.
And and that definitely, yes, is something that we need to consider.
Thank you.
Others,
Next up is Perry and then Shira.
Perry, your turn.
Hi there, Perry Grossman. Yeah, I just wanted to follow up on Susan's point. I'm concerned about that as well. Like, I guess you've said that other people aren't likely to come here, but do you have recommended resources on that and where we might look to that issue? Thanks. Coming to Massachusetts.
Could I also ask, between the time that Romney Care went into effect and Obamacare came around, how many years elapsed?
Romney Care was passed in 06.
In 06.
Obamacare went into effect in 2013, I think.
Something like that.
So it wasn't that many years.
It was most of a decade.
Right. But
Right. Quite
Yes.
a few.
okay. I'm sorry I interrupted, Perry. Is there, I mean, if it actually was a problem, if people really did with serious illnesses start moving to Massachusetts, if we pass this, what would be a solution for it?
Well, the legislation provides that people have to be residents of Massachusetts in order to be covered.
Not completely. I think part of it says that they don't need to, if they work 20 hours a week.
Yeah, if they work 20 hours a week in Massachusetts, then they're also covered. But we added the language probably 8 years ago, saying that part of the trust, they would have a duty to make sure people were actually living in Massachusetts if they were applying for care and coverage. So there is that safeguard.
But what if they
I-
actually move? I mean, people who have serious illnesses, our healthcare system being what it is, there would be an enormous incentive to move here, because it is such a generous bill. It doesn't only cover basic healthcare types of things, but also long-term care. I mean, if
Right.
you have a relative with dementia, that's such an extraordinary, expensive kind of disease to get treatment for. And but this bill apparently covers that.
It's true, but again, I guess I have to say we have a little faith in human beings, and when unemployment insurance, we have some of the highest unemployment insurance in the country. And every time the legislature talks about raising that, you have, oh, everyone's going to move to Massachusetts so they can collect high unemployment. Yeah, it doesn't happen. It didn't happen under Romney Care that everyone flocked to Massachusetts.
But
I
but,
guess.
but health is life and death sometimes. I mean,
Well, but
it's,
it would
as
have
you
been the
know.
same. It would have been the same for people with severe health conditions. If you lived in Texas and you couldn't get insurance coverage because you had pre-existing conditions, why didn't all those people move to Massachusetts where under Romney Care they would have to have insurance? It didn't happen, right? Because I think life is much more complicated than, people searching around and saying, maybe we're going to uproot a whole family, sell everything, move to a different state, and hopefully we'll get some health care.
And to an extent, that incentive currently exists, to David's point. I mean, Massachusetts has one of the most generous Medicaid programs in the country. We cover people, I think, up to 6 times the income limit of Texas. So there's millions of people in Texas right now who are ineligible for Medicaid who could move to Massachusetts and receive Medicaid, but they choose not to do so. We're the only state that offers paid family and medical leave through a state program. There's not been, in fact, not only are we not seeing people move here for this programming, we actually have net out migration for Massachusetts right now. So I don't know. I have yet to see any compelling data that
Okay.
is concerned.
Perry, what other questions do you have at this point?
That's it for now. Thanks.
Okay, we can come back and make another round.
Okay, next up is Shira Fisher.
Hi, Shira Fisher, Town Meeting Member, Precinct 11. Just public comment here in support of this resolution. I particularly appreciate the changes at the end. I think everything that everybody said so far about the details of this specific bill that's in the legislature is very strong and very relevant. There's some questions about how it would be implemented. There's some weaknesses, and that's why I think Brookline's take should be we support this concept and not necessarily specific policy, to encourage our representatives to work with their colleagues to develop the best version of this that's possible. It's still in the works. There's differences between the Senate and the House. There's the details that everybody raised, but that doesn't negate the basic concept, which, as Susan just said, people need healthcare, people deserve healthcare. We want to find a way to provide it. And just to comment on some of the questions that were asked so far, I think Alec addressed them, but just to reinforce, people move for very complex reasons. You can't just get up and come to Massachusetts because you want long-term care for your elderly relative. You sell a house in Texas, you can't buy a house in Massachusetts. There's cost of living issues, there's family issues. We haven't seen that happening. What might happen, which is kind of the goal, is that competing states might say, well, maybe we should implement this policy also. And that is what happened with the version of Romney Care that became Obamacare, that's the ACA. And that's what we would like to see for everybody across the country, everybody having access to care, everybody having affordable care. We can't do that right now at the federal level. So what we're going to do it as at the state level, and we can't do it yet at the state level. So what we want to say is Brookline is for this. We want to encourage our elected representatives to move it forward to the best version that's possible here in Massachusetts. And then Massachusetts could be a model for other states. And instead of moving here, they can just get it at home. So we would love to be a leader in this. Brookline has been a leader in all sorts of legislation in the past. We can't make it happen in Brookline because that's not how healthcare works, but we can at least call for it. There's no downsides to doing this except saying we believe in this concept and we'd like our representatives to speak on its behalf. Thanks very
Thank
much.
you. Thank you, Cher.
Okay, so
David, Mark, do you have question?
I'll just, no, not a question, just a very brief comment in that we don't want to frame the thing so much that it's mainly the insurance companies that are the big problem, because it's a three-headed problem. It's also the hospitals and the for-profit hospitals, which are raising rates, which then get sent to the insurance companies, which then get sent to us. And the pharmaceutical issue is also a huge part of the issue. So there are three distinct areas which all have to be tackled together coherently if this is going to happen. Alec, you had a comment.
Yeah, thanks, David, Mark. And I think you really touched on the main argument I think that makes sense to support a policy like this, which is currently we claim to have a healthcare system, but we do not have a healthcare system. We have a healthcare marketplace. And that creates incentives for every actor in that marketplace, like it does in any other market, to build as much market share as possible and use that market share to raise profits. It's monopolistic competition. It's why you don't just see for-profit hospitals consolidating, but also nonprofits. Market share is everything. The insurers are consolidating. It is literally an arms race between payers and providers in our current healthcare non-system. And the people who lose out are everybody else, people who access the healthcare system for actually needed care. I did want to very briefly touch on the Vermont example as well. And I did mention this when the select board heard this last week, but I really feel that Massachusetts has some unique characteristics in comparison to Vermont that could make this a success here where it didn't succeed in Vermont. One is size. We're talking about risk pooling. The bigger the risk pool, the easier it is to manage. You're talking about in Massachusetts a risk pool 10 times the size of Vermont and a total expenditure rate of about the same, about 10 times what we spent, or they spend on healthcare, we currently spend. I think our history as a leader on healthcare policy matters a lot. We've heard a lot about Romney Care tonight. There's also, I think it's worth mentioning, another state or nationwide healthcare delivery system reform that Massachusetts pioneered in the last 20 years, which is capping the growth of healthcare costs. In 2012, we passed the first in the nation model that created our Health Policy Commission. We now cap the increase in total healthcare spending as a state, and it's worked. It's not a perfect system, and obviously costs are very high. We started from a high cost basis. But if you look at how healthcare spending is growing in Massachusetts compared to many other states, you can see the impact of that model, and it's being adopted elsewhere. California's picked it up. Oregon's picked it up. A number of other states are now doing this same model. Right. So we've got multiple, repeated reform efforts that we've pioneered in the last 20 years, and they have caught on nationwide. And I think the other piece here, and I think a key component when you read the accounts of how these major healthcare reforms have passed in Massachusetts, is we have a very tight-knit health policy community here. And it's one that I think works very well collaboratively together, has less animosity, I'd say, than in many other state markets. And we have leadership on both ends of the table, I think, in this state that is open to innovation and experimentation. And that's, you don't have to take my word for it. You read the oral histories of Romney Care. It's a really fascinating story. But I really do think Massachusetts is well situated to be the leader here. And I just want to thank the petitioners for bringing this forward.
Now, the governor has not taken a position on this, correct? Or what I've heard is that her focus is on improving the current existing version of Romney Care. And but
I think that's true, but and the problem is they keep throwing money to a system where the insurance rates keep going up, hospital rates keep going up, pharmaceutical prices keep going up. and
How would this
throwing money at
prevent-
that.
I know that new medications such as the GLP-1 drugs and other things have thrown a monkey wrench into insurance companies, all sorts of medical funding predictions. Someone in this plan will have to vet requests for health care. It is not going to be simply anything that someone wants, they will get. Who is going to be making those decisions and on what basis?
So a couple of things just real quickly. You look at the new weight loss drugs and the profiteering that's going on around those are huge. Bernie Sanders released a study where,
Right.
I forget which one it was, said, the cost to manufacture it was about $8 a dose. In the United States, they were selling it for $800 a dose. In Canada, it was $300 a dose.
Mhm.
One of the things that we look at for our legislation is the healthcare trust will be very similar to the Veterans Administration. Veterans Administration now has the authority and bargains with drug companies over prices of drugs. And on average, the VA prices for drugs are 45% less than regular folks are paying for them. And so the VA serves about 8-9 million people, right? Which is the same size as the Massachusetts pool will be. So first thing is that'll be an important role of the trust is to bargain down, lower those prices.
And just another question. On the federal level, budgets don't have to be balanced. At the state, like the local level, budgets have to balance each year. What is the workaround for this so that it will not always be possible to be able to predict exactly how much people will be making demands that will be approved, but the budget has to balance. So what will be the way of accomplishing that?
Well, right now, the legislation says people will get all medically necessary services, right? That we don't want the state to be in the position of dictating who's going to live, who's going to die.
Well,
So
who's going to make that decision, though?
doctors, and there will be a fraud division set up if there is fraud to investigate that. But medically necessary decisions should be made by the doctor. We really look at that. The problem isn't one that people are going to be demanding expensive things. It's getting control on the costs, getting control over
Thank you. We
hospitals.
have 10 minutes. We
Yeah,
need to now reserve the comments just for the subcommittee members.
Susan Jackson put his.
Yeah.
You can skip me if we have time concerns.
Okay. Do we want to take a vote at this time? Are there any amendments that we want?
I'd be happy to offer a motion for favorable action as amended.
As amended by the petitioner.
Yeah, this
Yes.
version is a lot better that it doesn't prescribe too much in detail. It leaves the concept in place, but lets the State House work out the details.
Right. It doesn't endorse a specific piece of legislation.
Yeah. So I'll second.
Okay. Is there any additional discussion? Fran, you haven't said anything.
Well, I've been,
No, the other Fran.
so I'm so sorry.
Yes.
Yeah, Fran Perler.
And
Can you speak
agree with
louder?
the others.
What? I couldn't hear you, Fran.
I've been listening. I don't have volume on. And agree with everyone else. Thank you.
Okay, so why don't are we ready for a vote at this point? I'm going to say I have reservations and I've been somewhat torn because I don't necessarily think having Massachusetts be the first is necessarily in Massachusetts' best interest. Because I think in everything as major a development as this and as complex, this is far more complex than Romney Care ever was. It's going to require a lot of trial and error. Mistakes will be made. This is a test. And I would much rather not be the first one doing this. I would love to be able to be learning from other states' experiences, because the costs of making mistakes, of having not fully appreciating how expensive X or Y decisions will be, could have an enormous impact on whatever else the state has money to spend on other things that are needed by residents. So I am concerned, and I haven't decided yet what I'm going to do, but I support the concept. I would much prefer to see this as a federal program. I understand it's nice to have an incubator and have a test case, but I don't necessarily want Massachusetts to be the test, because I think that invariably mistakes will be made, just in the same way that insurance companies have made mistakes in offering long-term care insurance and then realizing that they mispriced it. I think that we don't really understand just how expensive the necessary healthcare will be. And particularly as the medical profession discovers more and more ways to improve our health, there will be more and more reasons to spend money on things that are now necessary that didn't exist decades ago. So I do think this is going to be a huge commitment. And I worry that we don't really know exactly what the consequences of decisions that the state legislature would have to make will ultimately be. Other people's thoughts at this
Yeah,
moment?
so I'm gonna support this, right, for multiple reasons. And in honor of our 250 years here, for one thing, Massachusetts, we do start things. That's just what we do here. So I'm gonna support it. And someone who works in the healthcare field, we have people that come in from all over the world here just because of what we do already. So I'm gonna support it. I understand it. I appreciate the concept of it, and we leave it up to Tommy and them to hash it out. But I support it. I like the language now. Thank you.
Okay.
I like your framing there, Donnell, and the 250. I'm like, this is Massachusetts. If we can kickstart America, we can kickstart fixing American healthcare. That's my take on it. So I look forward to voting for this.
Okay. Anyone else would like to say anything? If not, was someone, Fran,
is this the general public or?
This is now just the subcommittee
Okay,
deliberating on how we are going to vote tonight. Okay, I'm sorry, but this is the one time where we're not getting comments from the public at this point. So I've closed I should admit, the public hearing portion is closed. This is just the public meeting of our subcommittee. Okay, so are we ready now to vote? I can do a roll call at this point.
Yep, go for it.
Okay, Alec.
Yes.
David Mark.
Yes.
Donnell.
Yes.
Fran.
Yes.
Perry.
Yes.
Okay. Oh, what to do? I am so torn.
You've got 12 seconds. Hurry.
Okay. Oh, I guess I'm essentially an optimist, so I'm going to vote yes. But
unanimous.
Yes, I'm also a lawyer. What can you do? I mean, we naturally see all of the other sides of things. Okay, so the vote is unanimous. And of course, I think the fact that this is a resolution that is not prescriptive. It's encouraging, it's supportive, and I think that there is an opportunity to provide support for the importance of this undertaking. And but I still have my fingers crossed. Okay, this will be taken up by the full AC a week from tonight on the 31st. And Perry will be drafting the report. And so if anyone has a statement, a written statement that they'd like to submit to the full AC, you should send it to me and with a copy to Perry. Or you can just send it to me and I'll make certain Perry gets that, as well as the advisory committee administrative assistant, so that it will be distributed to, made available to the full AC. And that's it. So thank you all. We really appreciate having such a great showing. I think that we all learned a great deal at this hearing, and thank you.
Thank you, guys.
Thank
Good
you.
night.
Thank
Good night,
you.
everybody.
Night.
Thank you all.
Night.
See you on the